Again with another episode of Medics, Musings, and Mayhem. A couple of quick housekeeping things before we get into today's episode. First, I just want to reiterate once again that for those of you that are listening to us consistently, please be sure to go ahead and like and subscribe to whichever service you're listening to, whether it's iTunes, Spotify, or beyond. Because when you do that, that actually allows us to get a larger audience. And as you know, getting to more and more of the rural world as we know it is one of our major goals here. Second, we do have some pages up both in Facebook world and on Instagram, so please go ahead and take a look at those and give us a follow and share with your friends. Thirdly, we do have some new and exciting recordings coming out, including some origin stories of how Medics, Musings, and Mayhem began, so stay tuned for that to come out. Now we get to the good stuff. This is going to be our second episode of EMS Across the Pond, and let me tell you, since this first podcast went up, we have had over 300 listens in the last 2 weeks. So I think it's pretty safe to say that you all really like Regan and Livia. So, backed by popular demand, here they are to talk about their next big topic.
Hello and welcome to another episode of Medics, Musings, and Mayhem. I'm Regan, and we're back with Livia for another episode of EMS Across the Pond. Livia, it's an honor to have you back for another episode.
Once again, thank you for having me with you today, Regan, for another episode of EMS Across the Pond. As always, it is an honor to be here. And for those of you listening, you may recall that the last episode Regan and I did together covered point-of-care ultrasound, the FAST exam. This episode, we will be continuing covering my favorite topic in medicine and discuss what else we can be using ultrasound for in the pre-hospital setting.
So let's jump right into our case.
Last time, I took everyone to the mountains of Poland, and now Regan is going to be taking us to her own backyard in the old wilds of North Dakota to look at a case.
So it's a classic July afternoon, sunny, hot, no one's working, it's the nice summertime, and everyone is out on their 4x4s, their four-wheelers, their Rangers, whatever you like to call them, in the vast prairie enjoying that sun. And our EMS providers are out on their typical summer barbecue when we get a page for a 4x4 accident with a 51-year-old male.
Once you arrive on scene, what do you find?
We see our patient laying over the steering wheel of a 4x4. He appears to be unrestrained, and he does look over at you as you start approaching the vehicle.
Okay, so what do we see during our primary assessment, especially airway?
So as we walk up to our patient, asking them for his full name, he is able to normally say it, and you can see that fire has already placed a C-collar on him.
Okay, what about breathing and circulation?
So while you're simultaneously listening to your breath sounds and feeling for that radial pulse, you hear breath sounds on both sides and have a good, strong pulse.
Any disability?
Patient appears to be alert and oriented ×4, and he is moving all of his extremities.
Okay, anything to worry about in exposure?
Given that it is a hot day out, I'm talking about 90s Fahrenheit, we want to get him back into the ambulance so we don't also have heat stroke in there. So as we carefully remove him from the 4x4 to a stretcher into the back of the ambulance, all of his clothing is removed. We do see some bruising to the chest wall, predominantly on the right side, but there's no other obvious injuries.
Your partner, in the meantime, took some vitals. Our heart rate is 110, blood pressure 138/86, respiratory rate 23, and O2 sats 97%. While in the back of the ambulance, we get that second assessment underway. What do we find?
So our patient is able to describe the accident to us. As he's doing that, though, we notice he's becoming more and more short of breath. His sentences appear to be a little bit shorter and having a little bit more of a difficult time breathing. So that means it's time to reassess.
We're going to recheck those vital signs, and our monitor is showing us a heart rate of 140, BP of 105/79. Our patient is getting a little hypotensive, and a respiratory rate of 32, and our O2 sats are down to 89%.
So I'm going back to my head-to-toe assessment. reassessing to see if I can figure out what's going on. And while I'm listening to those lung sounds again, I know for sure I'm hearing our sirens, I'm hearing the engine running, I'm hearing the AC blasting, I do hear the monitor beeping, and I'm pretty sure I hear some lung sounds. I know for sure they're on the left. And as I'm glancing over at the clock, I know that I'm about 30 minutes out from the closest emergency department.
What are we thinking about in this moment, seeing that our patient is decompensating?
So my pulse is also starting to rise a little bit. There's a lot running through my head here. I can see that we have a decreasing O2 saturation. Might just be a reading error, but it could also be a pathology of the lungs and heart that I haven't found yet. He is a little hypotensive, definitely changing from our first vital signs. So did we miss a bleed initially? And are we no longer neurologically intact? We do have some worsening tachycardia. Maybe this is just from pain, but there could be something else going on. We have worsening tachypnea, so maybe this is more of a lung pathology. But as all of this is going through my head, the things I'm concerned about are pulmonary contusions, pneumothorax, blunt cardiac trauma, maybe even a tamponade, or even a hypovolemic shock due to an internal bleed that we just haven't caught yet. So for now, I'm throwing some oxygen on him with a non-rebreather as we continue to figure this out.
So it's been 4 minutes later, a whole 4 minutes, and we are reassessing the patient and they can barely speak to us. The vital signs this time on the monitor are showing a heart rate of 170, our blood pressure, it's all the way down to 85/50, that respiratory rate, 55, and O2 sats are 74. We have some serious decompensation as of this moment.
And with any reassessment, I'm going back to my head to toe. And on that, glancing up of the head, I am seeing distended neck veins and a little bit of tracheal deviation. And now I'm sure that I can't hear any breath sounds on that right, but they're still over on the left. And keeping in mind that we're in the back of the rig, I'm still over 20 minutes out from an emergency department. So this is the nerve-wracking part. I for sure have tachycardia going on right now, and we're nervous about a tension pneumothorax.
What are you going to do in the US specifically?
In the US, it can be a little bit of a scope dependent, but for most providers in the ambulance, they will be able to do a needle decompression for those tension pneumothoraces. So for us, we're going to get that needle decompression started and see if we can get some resolution of those decompensating vital signs. Usually they will start to bounce back when that lung gets reinflated. How about over in the European Union? What are you guys doing?
So we have a very similar situation where it's scope based, and depending on which region or what the available equipment is, most of the rigs and teams that I've met will do a needle decompression in the second intercostal space, in the mid-clavicular line, or a finger thoracostomy in the mid-axillary line in the fifth intercostal space. But I have yet to meet personally a team that does a finger thoracostomy.
Same with our service area. I know we can do needle decompressions, and I don't really know the closest place that are allowing for the finger thoracostomies, but it is something to keep in mind. This is another way to treat these kind of pathologies. So speaking of our pneumothorax, let's talk about that pathophys and how we do treat those. Simply put, a pneumothorax is air in the pleural space, when really all we should be having in that pleural space is our lungs. Having air in that area where it's not supposed to be is going to cause a loss of the negative pressure between the pleural membranes, and that can lead to partial or complete collapse of the lung. Now remember, our basic physiology, that negative pressure is actually what's allowing us to breathe. So a loss of that negative pressure, we're not really going to have any respirations, or at least not good ones, going on. Additionally, that air in that pleural space is going to increase the intrapleural pressure. This is pushing on that lung, causing the alveolar collapse, or just the little air sacs in the lungs. And that is going to cause any sort of blood going through the lungs to not actually be ventilated. So this is causing some shunting from the right to the left. Blood is still rolling through, but there's no exchange of that carbon dioxide and oxygen. So there's not really any benefit of it going through those collapsed lungs. So there are two types that we're going to see. A closed pneumothorax, and this is when air is entering that pleural space, typically through a hole in the lung, such as following blunt trauma like we talked about in our case, or an open pneumothorax, and that's when air is entering actually a hole in the chest wall, such as in penetrating traumas. Either one of these kinds of a pneumothorax can lead to a tension pneumothorax. Now, this is a life-threatening variant because of the progressively increasing pressure in the chest, leading to cardiorespiratory compromise. That increase in that pressure, usually through this one-way valve, so air is going in, but it's not able to get out, causes a huge accumulation of positive pressure within the chest. That typically is going to lead to a collapse of the lung and compression of the lung, trachea, heart, and vasculature on the other side of the collapsed lung. Now, if we're compressing this vasculature, we are not getting adequate venous return to the heart. Then we're not getting adequate cardiac output, and then we are having hemodynamic instability. So this tension pneumothorax is very life-threatening because it actually just compresses all of our ability to keep blood pumping through our body and oxygenating all of our tissues. So now treatment for these, for a pneumothorax or a tension pneumothorax, you want to get supplemental oxygen on board to help with any sort of exchange that's still happening in the non-collapsed tissue. You also need to relieve the pressure. This is going to come in the form of a needle thoracostomy or a needle decompression. For a needle decompression, we are inserting a large bore needle into the second intercostal space, typically at the midclavicular line. And this is usually followed by a chest tube placement, but that's not happening until our patient gets into the emergency department. Now, out in the field, if our initial decompression fails, you usually can use a longer needle or have the same size needle going adjacent to the needle you already placed. And if it is allowed in your service area, you can absolutely do the finger thoracostomy. After either one of these interventions, we need to make sure we have adequate analgesia for these patients. It cannot be fun to have a needle stuck into your chest, so keep in mind that there is a human that is experiencing this, and we need to give them adequate pain control. So now on to the main topic of this episode. How can we use POCUS, or point of care ultrasound, in cases like this? Livia, take it away.
We're going to be talking about an EFAST. That is an extended focused assessment with sonography and trauma. In the last episode, if we remember, a FAST exam uses ultrasound to detect free fluid in the peritoneal space and the pericardial space. Whereas an EFAST is going to take it a step further to take a look at those lungs to detect possible pneumothorax or hemothorax in our trauma patients. Just like in the last episode, let's cover those ultrasound basics again, just as a reminder before we dive into the main topic. We have three main ultrasound probes: linear, curvilinear, and sectoral.
Me again, just popping in for a brief second. So Livia was talking about the probe types, and she talked about linear, curvilinear, and sectoral. For those of the US, this is also known as the phased array probe. So this is the one that has the smallest footprint or the amount of surface area that's going to touch the skin. It's the little rectangular or square probe. Just wanted to clarify that for y'all.
As I said last episode, on a rig, you aren't going to have a full-blown machine. Instead, you'll have something more compact, like an electronic screen to which certain probes can attach to. We said that for the purpose of a FAST, it's best to use a curvilinear probe because it operates at lower frequency, which means it sees further away, but less clearly. However, when looking at the lungs, we don't necessarily want to see further away. So instead, ideally, we would use a curvilinear probe, which operates at a higher frequency, meaning we have shallow penetration, but very high resolution. However, if all we have is a curvilinear probe, we can use that. Let's also talk about some key structures to look out for and remember in our images that we capture. All the bones will appear black with that white rim around them. Anything under the bone will be hidden because those ultrasound waves cannot pass through. In most cases, fluid is our friend because it provides the best acoustic window for ultrasound waves. Free fluid is going to appear black, while well-vascularized structures such as the liver and spleen are going to be a darker gray. Things like the pericardium, pleura, and various fibrous capsules of the organs are going to appear white since they tend to be more reflective of ultrasound waves. Since today's topic of discussion is lung POCUS, it's important to remember air is not our friend in the case of ultrasound waves because it scatters and distorts our image. If air distorts that image, why bother doing a lung ultrasound? It's because air in the lungs is physiological. We expect it to be there, and we can learn how to recognize how it shows up on our screens. We can also look at how the pleura surrounding the lung is behaving, meaning we can actually determine if the lungs are expanding and contracting during respiration. Once we recognize physiology, we can also determine if there's any lung pathologies. Before we place that probe on the patient, I think it's important in pre-hospital to be able to differentiate and understand three main concepts: dry lungs, wet lungs, and sliding. Dry lungs are lungs that on an ultrasound show predominantly A lines. What are A lines? Those are horizontal, echogenic, whitish gray lines running parallel. I repeat, they run parallel to the pleural line, and they should be about equidistant from each other. These lines are created when the ultrasound beam interacts with the air in the lung alveoli. Normally, a dry lung suggests a well-aerated lung. However, to be certain, we need the presence of both A lines and normal lung sliding. Wet lungs are lungs that on ultrasound show predominantly B lines. B lines are vertical artifacts that appear as echogenic lines and extend from the pleural line into the lung. B lines are normally the result of fluid accumulating in the lungs, interstitial edema, or fibrosis. Something important to note: B lines, no matter how much you increase the depth on the ultrasound, those lines will extend through the lung field, while A lines, after a certain depth, just start to disappear. Lastly, lung sliding. So I promise, no more lines to know, just A and B. Lung sliding is a normal finding where the visceral and parietal pleura slide back and forth on one another as the patient breathes. Some say this looks like tiny ants marching on a log, or call it the marching ant sign. As mentioned earlier, seeing both A lines and marching ants normally indicate normal aerated lung. With those things in mind, let's place that transducer on our patient. We are going to be looking at the left and right lung apex and lung base. To view the left and right lung apex, we should place the probe perpendicular at the midclavicular line at the second or third intercostal space of the right and left lungs respectively. What we want to see on the screen are two ribs, and between them a window where we can see that pleural line. Again, that's going to be a bright line between those two ribs that we see. And we're determining the presence of lung sliding as well as if we see A lines. This point is the most sensitive spot for looking for pneumothorax in supine patients. To increase the sensitivity of the examination, we're going to be looking at the pleural surface at several places along both the anterior and lateral chest walls. In trauma, when patients often present supine with spinal motion restricted, the most likely place to find a pneumothorax is anteriorly, so in that lung apex. However, patients can have an isolated lateral pneumothorax. That's why it's good to check multiple locations on the lungs. On ultrasound, if there is a pneumothorax present, instead of observing the marching ant sign, we'll just see a bright white line with none of those tiny black ants marching back and forth, and also no A lines will be present. To view the lung bases, we can actually place the transducer on the patient in a similar manner as when we were doing a FACEP exam, checking the right upper quadrant and left upper quadrant. Only we want to slide that transducer a little bit higher towards the patient's head to have the lung in our field of view. As a reminder, how are we going to find that upper right quadrant and left upper quadrant? We're just finding the xiphoid, dropping down, knuckles to the bed, probe held perpendicularly to the patient, and then we are sliding upwards until we see the diaphragm and the lung base. This location in both supine and upright patients is the most likely location for fluid to accumulate, meaning seeing those B lines. But in extreme cases, in very critical patients, we could have B lines all the way up in the lung apex. Why do an EFAST? What are some of the benefits? As in every case, it's going to improve our diagnostic skills, especially in critically ill patients like trauma victims. Osculation might be challenging as dorsal lung fields are difficult to reach in supine physician patients, and the environment is often noisy in our rigs. In fact, in recent years, not only physicians but paramedics have started to consider lung ultrasound as a very useful diagnostic tool for a variety of other pulmonary pathologies, like the aforementioned edema or even congestive heart failure. Lung POCUS really gives us the extra eyes when our ears may be in a loud and chaotic environment. In fact, Regan is actually going to talk about a really cool EBM study discussing how just osculating that patient in loud environments may not be as effective as we think. And of course, the tried and true. Ultrasound is going to provide us that baseline of anatomy and physiology and just help us keep track of the progression of our clinical diagnosis. What's happening with our patient and how is it progressing?
Livia, I always learn so much from you when you're explaining anything along ultrasound. And of course, learning ultrasound via any modality is going to increase our knowledge bit by bit, but it is easier when you're seeing and doing it with your hands. So, to aid in Livia's explanation, we're going to add some resources to our website and also our Instagram. So, take a peek. And like Livia mentioned, I do have a study for us in our evidence-based medicine that characterizes how our assessments of breath sounds go during an ambulance transport. Now, this was published in the Annals of Emergency Medicine, and it was comparing listening to lung sounds in a quiet hospital room, so the control environment, versus a moving ambulance. Now, this study found that the accuracy of a breath sound assessment in a controlled environment was about 96%, 96% sensitivity, and a 97% specificity. Now, the accuracy of breath sounds in the experimental side, or the moving ambulance, was actually only about 54% of a correct assessment. The sensitivity was 0.09, and the specificity was still up there at 98%. But again, that sensitivity was 0.09%. So this study showed that participants were significantly less likely to hear breath sounds in the moving ambulance than in a quiet room.
Well, I don't know about you, Regan, but I'm not ready to be missing half of my patients' pneumothoraxes just because I can't hear in the environment that I am.
I agree. That's a scary thought to put a number to. Like half of them you could miss. So, to add to our evidence-based medicine corner and to support our talk about POCUS with lung pathologies, I found another study that's a comparative study on bedside chest ultrasound versus chest CTs in the diagnosis of traumatic pneumothorax. So this was posted in the Cardiothoracic Surgeon Journal. It went through 200 patients that were admitted to the emergency department for blunt or penetrating chest trauma. These were mostly due to motor vehicle accidents, similar to the case that we have in this episode. Now, all of the patients received a POCUS exam and then had a CT of their chest. Now, the CT found 47 pneumothoraxes in 200 patients that were examined. The ultrasound was able to identify 45 of these, and the 2 that were missed were very small, but still, it did miss those. That gives us a sensitivity of 95.74%. There were absolutely no false positives in the ultrasound, meaning that it had a 100% specificity. Now, there are a couple limitations to this study. First of all, the ultrasound was performed by a senior emergency medicine physician who had plenty of years of experience, typically more than 4, in doing an EFAS scan. So those sensitivities and specificities are likely to be a little bit lower in newer physicians and in EMS personnel. Also, this study was predominantly male patients, about 80%, so that does limit the study's generalizability. However, bringing it all together, compared to the CT scan, POCUS had a sensitivity of that 95, almost 96%, with 100% specificity for diagnosing a traumatic pneumothorax after blunt or penetrating chest trauma. And this is just adding to this growing amount of evidence that ultrasound in the hands of a very experienced examiner or a well-trained examiner can actually be a fast and reliable way to find a pneumothorax. Putting both of these evidence-based medicine articles together, we know that in the back of an ambulance, it can be really difficult to properly assess lung sounds, but we have a tool that is really fast and reliable for looking for a pneumothorax. So let's jump back into our case. We had this 51-year-old male who got into a 4x4 accident, had some blunt trauma to their chest, and in the back of the rig, a tension pneumothorax was found. In the United States, we're treating that with a needle decompression, or in some service areas, a finger thoracostomy, and we will be reassessing by listening to the presence or absence of those lung sounds and continuing to treat that if needed. But Livia, you guys are going to go a step farther and put that ultrasound probe on the patient. Tell us what you're going to see.
So in the case of our patient, I would have done that full EFAS exam. Our FAST exam would have been negative of any free fluid in the peritoneal space, while an examination of that right lung apex would have revealed the absence of lung sliding and no A-lines. So it confirms our diagnosis. And even cooler, after treatment with needle decompression, we're able to immediately assess the effectiveness of our treatment using ultrasound. And even if there's minimal breath sounds, we can see it and we know for sure that it was effective. I don't have to guess. I don't have to flip a coin and say, do I hear it? Do I not? Because even when we do a needle decompress, are we always going to hear that air coming out of that lung from that small opening in the chest wall? No. Am I always going to hear those shallower breath sounds when there's lights and sirens? No. But will I see those ants marching? You betcha.
Livia, it is always an honor to have you on, sharing your knowledge of ultrasound with our listeners. I greatly appreciate it. And even though this was slightly shorter than our last episode, I feel like I learned just as much. I hope you're willing to come back because I would love to learn a little bit more about the cardiac ultrasound.
You know what? I think I will come back and let's talk about that cardiac ultrasound.
So, as Doc always says, may your mayhem be well controlled, full of teachable moments, but also provide you with the opportunities to provide your patients with the best care possible. Thank you for listening.
Man, I'll tell you what, every time I listen to these two, it just gets better and better. Despite only being medical students, they have so much good insight and so much good learning already acquired through their training. A couple quick things I just wanted to rehash from the talk today. First and foremost, you're going to have two types of pneumothorax, right? You're going to have your closed pneumothorax, which is due to blunt trauma typically, and then you're going to have your open pneumothorax, usually due to a penetrating trauma of some kind. In the severe cases, when we get to the tension pneumothorax, this can be diagnosed clinically, but sometimes pneumothorax can be much more subtle. And as Regan alluded to, the studies have demonstrated that when you're on a noisy ambulance, it's very hard to sometimes hear those breath sounds. So this is where we get to enter point-of-care ultrasound again because it is such a valuable tool. Again, this is one of my soapboxes to get on. This is a tool that needs to be done well and practiced often in order for us to make good assessments with the ultrasound probe. And it does not replace a good primary and secondary assessment. If you have the time, being able to do the ultrasound assessment is very helpful. And like Livia had said, be sure to look for those ants marching and to look if there's any sudden vanishing of those ants marching, which might point to a pneumothorax. We also talk about lung point sign, which basically means that you track along the chest cavity until all of a sudden the sliding that you see stops. And that's another indication that over that particular distribution, there is a pneumothorax. One last point when it comes to using ultrasound when looking for tension pneumothorax. As Livia talked about, when we look for pneumothorax in a trauma situation, generally speaking, you're going to see roughly about 80 to 90% of pneumothoraces presenting over the anterior chest cavity. So typically we teach the residents and fellows that if you're looking over the anterior chest, you're going to generally find most of your pneumothoraces just because when patients are laying flat, gravity is going to allow for the open space to be more over that anterior distribution. It's just the way that the lung sits dependently in the context of laying supine. However, if you want to be even more certain that you have ruled out pneumothorax, as Livia said, you want to make sure that you're checking at the lung bases too to see if there's anything going on laterally, as well as if there's any fluid collecting in the lung bases such as blood. Once identified, the question becomes, what are we going to do about it? And like Regan and Livia alluded to, option one would be to do a needle decompression. Now, in the US, the guidelines have changed recently because the ATLS 10th edition has basically done away with the anterior needle decompression. This is mainly due to provider comfort. Remember that all specialties, especially in the rural setting, get some degree of ATLS training, and some are just less comfortable poking over the anterior chest due to the various structures that are in place over that second intercostal space. So nowadays, we generally just recommend going to that fifth intercostal space over the mid-axillary portion to make that decompression right there, as there's less structures available. The same holds true for when we talk about finger thoracostomies. I would recommend going to that fifth intercostal space in the mid-axillary line. A quick cheat, if you're in the moment and things are stressful, just remember to go to the nipple line in a male or to look for that inframammary fold in a female. Also, for you movie buffs out there, if you want to see a great illustration of a tension pneumothorax, check out the Three Kings movie. This actually has a great example of tension pneumothorax and what happens physiologically once a needle is introduced into the space. Be warned, it is a graphic illustration, but I think it's such a great example of tension pneumothorax in a patient. Lastly, pain control. Super, super, super important. Remember, if we're going to do any type of procedure that's going to go into the chest cavity, it will hurt. So whether you do a finger thoracostomy or if you put a needle in to decompress the lung, I would highly recommend that you get some pain control either right before you do it or right away afterwards. So I think that's just about going to do it for us in this week's episode. Thank you so much for listening. We appreciate hearing from you all, and I hope to keep hearing more from you in the future. But today, I'm going to let Regan take it away.
May your mayhem be well controlled, full of teachable moments, but also provide you with the opportunities to provide your patients with the best care possible.
Blooper reel.
Oh, I probably should say 90s Fahrenheit.
That's you.
That is me, right?
Yeah.
I think I just read your line.
Yes. Sorry, Phil.
No.
So sorry.
Why did we pick such hard words? Okay. Sorry, Phil.
Interstitial edema or FUD. Phil, I'm going to redo that last part, okay?
Yeah, redo it. Go ahead. Sorry,
Okay.
Phil.
Blah, 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 blah.